Okay, so this is the last part of the video series on acute hemorrhagic diarrhea syndrome, and in this last part we're going to split it into two videos just because there's a lot of content, but we're going to be talking about nursing management of these patients. So first off, fluid and electrolyte balance, because as we talked about, fluid has got a massive part to play in these patients' pathophysiologies and therefore their treatment. So here is a chart that depicts fluid proportions throughout the body. Apologies that the writing is quite small, but essentially what we're just trying to illustrate is that the body is a large percentage water, and when we've got disease processes that create a lot of water loss in the body, so vomiting, diarrhea, polyuria, that water has got to come from somewhere, and normally that comes from losses into those spaces, and those losses are refilled by the plasma. So plasma takes up approximately 5% of total body weight, and that is within the intravascular fluid compartment. And this is the compartment that will rehydrate the extracellular fluid space, and that's the fluid tends to go from there into those losses that we talked about. So we as veterinary professionals have access to the intravascular compartment when we give IV fluid therapy, and that's how we try and fluid resuscitate and rehydrate these patients. So I've done this slide which depicts calculating fluid rates. And I've got this depiction at the bottom of these really distinct fluid therapy phases. So we have resuscitated fluids, so that's where we're giving those large bolus amounts of fluid in small spaces of time, and we aim to do fluid resuscitation over a short period of time. That can be sort of 10 minutes up to an hour if we're doing repeat boluses to try and get to a state of not being hypovolemic anymore. And then the next step would be to think about rehydration, so that's what we correct over 24 hours. And we have this chart here which depicts different clinical signs and what percentage dehydration we associate that with, what we attribute that to, and those percentages can help us calculate how many mils that we need to give to the patient in order to rectify those states of dehydration. So in terms of the calculation and the fluid calculation that we do, to work out how much the fluid is in deficit, we look at the percentage, we turn that into a decimal, so we divide it by 100. So for example, in the 5% example it becomes 0.05, in the 12% it becomes 0.12, and we times the patient's body weight by that decimal number, and that will give us the number of litres to replace. So that patient in this example of 8 kilo patient who's 5% dehydrated, they will need 0.4 litres in order to rehydrate. And as we know, that would be 400 millilitres, and that's important that it's to rehydrate over 24 hours, so that 400 ml is to be administered over 24 hours as part of our fluid rate. Our maintenance fluid therapy stage is the last one, and this one is where we have got euvolemia, where we're not dehydrated, we're not hypovolemic, and we need to consider matching the fluid intake with our insensible and sensible losses so that we don't get to a stage of dehydration again. This slide looks very intense, but feel free to pause and just work through it in your own time. As we discussed in the last slide, we've got this dehydration calculation which tells us how many millilitres to replace over 24 hours. In this instance, if we've got a patient that's losing more fluid as a result of, say, diarrhoea, you can estimate those losses by sort of weighing Inco pads, for example, and sort of if you weigh two and they're roughly the same, you could extrapolate that and sort of roughly predict that that's going to be the case for however many frequencies of consistent diarrhea or vomiting that they're having. So in this calculated example, this patient is losing approximately 1.2 litres every 4 hours in diarrhea, so that's 200 millilitres each instance per 24-hour period. So we work out how many mils over the 24-hour period that is. So this is 0.2 litres, so that's one event, times by 6 events, because if it's happening every 4 hours, it's going to happen 6 times in 24 hours. So this patient is losing 1.2 litres of fluid in their diarrhoea over a 24-hour period, and we know that at presentation they were dehydrated by approximately 0.4 litres. So we used that in conjunction with a maintenance fluid therapy calculation to create a final rate, and that rate would be the case for 24 hours, not anymore, and we need to reassess every day. So in this example, you can calculate maintenance. I got the 60 ml per kilo per day from the Ettinger sort of internal medicine textbook. I feel like it's a bit chunky. You can also use the body weight calculation, the kilocalories that you normally would calculate for the calorific requirement for a patient per day. You can convert that straight into millilitres, and that's how many millilitres that patient requires as a sort of maintenance to balance their insensible and sensible losses if they've not got any disease processes going on. So I did the calculation based on the maintenance one on the left, but you could also use the right. So we just add up all of those values. So we've got the 480 millilitres, which is the maintenance, plus the 1200 millilitres, which is the losses, the diarrhea that we worked out, plus the 400 millilitres of dehydration, and that creates 2080 millilitres to be delivered to this patient over 24 hours. And this, I suppose, is insinuating that this is the only route of hydration, of fluid accumulation this patient's receiving. If a patient's on tube feeding, if they're on lots of intravenous medications, you can also take all of those fluids into consideration, so we don't end up with like fluid creep, where we've got an accumulation of lots of fluid in these patients. And that's something that we consider quite a lot with critical care, is trying to not over-effuse these patients with these fluids that we don't think about giving, our flushes, our diluting to give antibiotics. So this is a calculation, but it should always be taken with a pinch of salt and consider the patient as a whole, as what our vets will do. And ultimately it's a veterinary prescription, so everything will have to be prescribed by our vet, but it's nothing to stop us doing the calculation and looking through what we think our patient would benefit from. So in this instance, if we've got 2080 millilitres over 24 hours, we can divide that by 24 hours and divide that by 8, or divide by 8 and 24, and we get mil per kilo per hour. So after 24 hours, we could then further reduce that if we remove that dehydration factor. Because after 24 hours, as we know, that patient should be rehydrated, and then we only have to consider the losses and the maintenance. And hopefully we then don't get to a stage where we're having to do resuscitative fluids again, because if we're keeping on top of our fluid therapy plan, we hopefully won't get that far behind. But sometimes this disease process can be really aggressive, and we have a lot of fluid losses. So it's all things to factor in for these patients, but fluid balance is really, really important to make sure that we don't get to that stage of cardiovascular decompensation. And this is where nurses can have a really vital role in monitoring all those cardiovascular parameters, also respiratory parameters, because if we have overeffusion, we might be seeing signs like tachypnea and exophthalmos and sort of nasal discharge. So as inpatient ward nurses managing a patient with acute hemorrhagic diarrhea syndrome, we're thinking really closely about cardiovascular stability and fluid balance. So the other part to consider with our fluid therapy is electrolytes and our acid-base status. So as you can see on the right, we've got a example of a blood gas analysis. So this shows us the acid base, the pH of the blood, and it also gives us lots of values, lot of biochemical information that can give us clues as to what's going on in this patient, and it will also give us electrolyte information. So in this patient, I've highlighted the key bits in red. So the pH is 7.28. Our normal is considered between 7.34 and 7.45. So this patient is below 7.35. So this would therefore be an acidemia. We're closer to that acid pH than the alkali. So this patient is acidemic. We've got a low CO2. So if we've got an acidemia and a high CO2, and they're going in the opposite direction, then that's the cause, or typically that's the cause of your pH being low. If they're going in the same direction, if you've got a low pH and a low carbon dioxide, that's indicative that it's not the respiratory system that's driving this acidosis, that it's something else. So it's always important to look at the carbon dioxide as well as part of our interpretation of this pH. We can see our base excess, that's our BE, so that's the second box down that's highlighted. That is really high number. So that number is -13, so that's very low. So what we're looking at is what's our balance of bases, and the negative number means that we have got less than we need. We've got a negative amount. Normal is between -2 and sort of +2. So this patient has not got a lot of buffering agency within the pH within the blood, and that's meaning that we have this acidemic blood. Lastly, we've got lactate. So as we know from when you've got like leg burning after you do some exercise, you've got a build-up of lactic acid. Lactate is a sign that we've got anaerobic respiration going on in our tissues, and we then have lactic acid as a byproduct of that anaerobic respiration. So if we've got anaerobic respiration, it's because we're not getting oxygen delivery to those tissues, and that could be because we've got poor perfusion. So that's where we have that instance of like vasoconstriction, for example, where we try and the body tries to increase the blood pressure by increasing the tone of the vessels and vasoconstricting. And whilst that maintains good blood supply to the vital organs, it might be that we have a lower amount of perfusion in the periphery. So if we're taking a blood sample from the distal cephalic, that might be, or even like, a saphenous, it might be that those tissues are less perfused, and we've got that higher lactic acid production, and that's represented in this high lactate. So we normally wouldn't expect a lactate above, say, 2. I mean, maybe you tolerate between 2 and 3, but definitely 6. We've got a patient who has got a metabolic acidosis. So for these patients, I would expect lactate to decrease with rehydration. So within 24 to 36 hours, that lactate should massively be reduced. The metabolic acidosis I would expect to improve with hospitalisation. It's not going to correct in the short term. We've got losses in bicarb with our GI system, in that we've got lots of diarrhoea, and it's natural for us to lose bicarbonate through our GI system. So if we've got extra losses, it'd be extra hard for us to hold on to that bicarb, so it's going to be more likely that we'll have that metabolic acidosis moving forwards. So it is important to consider with these patients regular blood gas monitoring, and that also helps us identify electrolyte derangements. Classically, with patients that are hospitalised that aren't eating, their potassium will fall. That's because we lose it naturally as part of urination, and we aren't able to make it in vivo. We have to receive it from our diet. So we need to make sure that we're supplementing these patients with potassium if they're not eating full RER, and regular blood gas monitoring will give us that information, or electrolyte monitoring on a biochem machine, any kind of monitoring where you're regularly reviewing that potassium. I've included on this slide a chart, and the blood gas result will, or the potassium serum concentration, will help guide the prescription decision for the vet. And it's important to regularly reassess that, because if it's, say, quite depleted at presentation and we go for quite a chunky potassium supplementation of our Hartmann's fluid therapy, it may be that after 24 hours the patient's eating a little bit more, and therefore it might be appropriate to reduce that potassium supplementation and make a new bag and flush a whole new giving set and start again. It's equally important that we should never bolus potassium spiked fluids. This can cause a bradycardia because of the dampening that potassium has on the heart. It will dampen that electrical activity, and that makes it harder for the heart to create a beat. So we never want to bolus potassium spiked fluids. And equally, we want to make sure that our patient doesn't become hyperkalemic. So if they start eating and they're on potassium supplementation, then that might be a cause for us to ask the vet, have we considered doing a repeat blood sample just to see what our potassium is looking like. So The next thing we're going to talk about is pharmaceutical support. So in patients that have, say, sluggish peristalsis, they might have signs of ileus, like a large dilated fluid-filled stomach, or they might have sluggish intestines that on point of care ultrasound there's no motility there, or there's very poor motility. These patients may benefit from a prokinetic, and in hospital, in the ICU and across Langford Vets, Small Animal Hospital, we use a metoclopramide CRI. There's some evidence to suggest that you can give it as like a bolus dose, and it doesn't necessarily have to be a constant rate infusion, but this is the way that we administer it here, and that's our protocol. So we give a metoclopramide CRI as a prokinetic, and we have been increasing our doses beyond 2 milligram per kilogram per day, which was classically the maximum that we would utilise. The risk of giving high doses of metoclopramide or giving metoclopramide too quickly is potentially neurological signs, neurological dysfunction in the short term. So that's why we give it as a CRI, and that's why we're cautious about increasing the doses, and we might not punt straight for 4 mg per kg per day. But there is data to suggest that you can go as high as 5. But in the hospitalised patient, it's important that if you are giving higher doses of metoclopramide, that we make sure that our drug calculations and our CRI calculations are on point, so that we're not overdosing this patient with inaccurate rates or concentrations, and that we are monitoring them for signs of neurological changes just in case. So that's a metoclop CRI. We also utilise meropenem. These patients can be feeling really nauseous. We've got all of that inflamed GI tract that's going to be dysregulating normal feelings and making them feel sort of nauseous and gross. And I do think meropenem really helps with that. Underneath that, in the image, you've got ondansetron. So meropenem is an antiemetic, but ondansetron is an anti-nausea agent, so that can sometimes be really effective at reducing that nauseating feeling which they might have without necessarily the vomiting. Omeprazole we would only give for patients that are showing signs of reflux or regurgitation. Omeprazole's job as a proton pump inhibitor is to increase the pH of the stomach acid, and if we've not got regurgitation or reflux, it doesn't actually reduce the incidences of vomiting by increasing the pH of the stomach. So we wouldn't say that that's an indication to give omeprazole, but we would if we were having reflux or regurgitation. So that might go hand in hand with a patient that's got ileus who is on a metoclopramide CRI, for example. So I would normally maximise this pharmaceutical support for 24-36 hours. We would try also all of our nursing care. So that might be taking them to the food kitchen and getting them really excited about the dog bowl, opening the packet, trying to recreate what it might be like at home for that patient to eat, not just sort of putting food in the kennel for them, because that might be quite an odd feeling. If they're crate trained, they might never have food in their crate, etc. So trying to know what's normal for them. Do they have normal foods that they enjoy, flavours, etc. Equally exploring more bland food options, because sometimes the hot, smelly ones that we get taught about that, you know, patients that are nauseous might then be tempted to eat, like the rich ones like pate, etc. I find sometimes actually they quite like a hypoallergenic dry, like a bit of dry toast equivalent, if they're feeling a bit nauseous and rubbish. So make sure we do offer a range of foods. I'm not a huge fan of the buffet platter just being like left in the kennel. And if a patient is extremely aversive on offering any food, immediately remove it. There's no point leaving that in with the patient. I would only leave food in with the patient if they sniffed it and maybe showed minor interest, or they sniffed it and maybe were a bit worried. And you might think that by leaving them alone, privacy blanket, a bit of Adaptil, maybe that will increase that patient's potential to eat. As I said, I'm not really a huge fan of platters. I would just try little amounts at intervals and try and separate the negative interactions, so like the tableting or syringing medication. I try and separate that out from food. I also think that walking a patient outside and then offering the food outside, or having the food bowl out on the floor when they get back into their sort of accommodation area, that can be a bit of a prompt to them to consider it in a different light, rather than if they're asleep in their kennel when you put food in. That doesn't always feel like an interaction where they would want to eat. So just try and promote opportunities for voluntary nutrition before we try appetite stimulation, because I think it's a bit cruel to stimulate a patient's appetite if they're then also feeling really nauseous and gross and sluggish and etc. So I think try and get on top of that. And then we try appetite stimulation. So we've got Entice on the market, which is caprimorelin, and that's a licensed appetite stimulant for dogs, and it's a ghrelin agonist, so it's literally designed to promote appetite in these patients, which is excellent. Mirtazapine in cats is Mirataz, and that's the licensed version, and that's transdermal, and it's brilliant, especially in sort of fearful or worried patients where you're also trying to get gabapentin into them, and you sort of leave it in a little treat in their kennel and you've rubbed it on their ear as part of the examination. So I think Mirataz is really excellent to have as part of the stock for your inpatient medication selection. And I always think that ideally we pick from licensed medication rather than cascade. So ideally, in theory, we should be going for caprimorelin over mirtazapine for dogs, but equally, if they're poorly responsive to one or the other, our vets can interchange between the two, and if we've tried one, we can always suggest that they try another whilst we're not allowed to prescribe. We can certainly have open conversation with our vets about what pharmaceutical support these patients may benefit from to try and promote that nutrition, to try and promote that gut healing, and try and get to our patient more towards homeostasis. So that's the end of this part of the video, and then in the next part I'm going to go on to the last part of nursing management, where we're going to talk about nutrition and skincare.